My name is Julia Grabsa. I'm the editor-in-chief for JACC Case Reports. And today it's a great pleasure to record this webinar on the mini-focus issue on complications in electrophysiology with Dr. Andrea Natale and Dr. Antonio Sorgente. I would like first to start by introducing Dr. Andrea Natale. He's a world leader in electrophysiology. He's the executive medical director of the Texas Cardiac Arrhythmia Institute and St. Davis Medical Center in Austin, Texas. And he's the national leader and CEO of cardiac electrophysiology for HCA Healthcare. So he has trained thousands of cardiologists in electrophysiology, and it's a great honor to be here with us. Also, Dr. Antonio Sorgente, he's the associate section head of the EP lab at the Picura Center in Belgium, and he's the CEO of Brain and Heart Company. He's also one of our associate editors for JACC Case Reports and editorial consultant for JACC Clinical Electrophysiology. So thank you very much for being here today. I would like to go ahead and start with the first case that has the title 1% aspiration and 99% perspiration, acute left atrial thrombus during percutaneous left atrial appendage occlusion. And the first author is Dr. Pankaj Jain from Cardiology Department at St. Vincent's Hospital in Sydney, Australia. Antonio, I would like to start with you. If you could tell us more about this case.
Yes, first of all, I would like to thank you, Julia, for this kind invitation and the honor to be part of this podcast with Dr. Natale. It's really a great pleasure. So getting started with the first case, it's a case of a 71-year-old man with chronic atrial fibrillation who actually was referred for an insertion of a left atrial appendage closure device because of a history that was really very complicated. He got a very difficult management with warfarin, and he got also recurrent gastrointestinal bleeding, and as also the iron deficiency anemia. If you can go ahead with the slide. This is the summary of the patient's medical history. He has also an important contribution of his peripheral artery disease. And so there was a combination of a very high CHA2DS score of 7 and an Asbled score of 4. You can go ahead if you want. So this is a very nice video. The authors actually submitted together with the case, and we can appreciate in the intra-procedural transesophageal echocardiography the presence of echo contrast within the left atrial body, but as well we can actually appreciate very well the presence of a thrombus in the apex of the left atrial appendage. The authors and the operators themselves made a decision to go ahead with the procedure, even if there was this thrombus in the left atrial appendage. And this is known to be a contraindication for the implantation of left atrial appendage closure device, but they decide to go ahead with the procedure with the intent to aspirate the thrombus before implanting the left atrial appendage device. You can go forward. So this is actually how they decided to go ahead with the procedure. The patient was heparinized before going for transeptal, and they actually went successfully through to the septum and to the left side, and they aspirate the thrombus through the sheath of the device, and they finally succeed in implanting the device itself. You can go ahead. And yes, this is the picture, I think, of the thrombus and during the implantation of the device and the echo contrast. You can go ahead. And well, the the transesophageal echocardiogram at the end of the procedure demonstrated no residual thrombus within the left atrium. And so actually the sheet was actually withdrawn to the right atrium after the device was deployed in the left atrial appendage. And I think the most striking picture of this case report is what is shown in the next slide. Go ahead. Yes, no, this is the video of the implantation, after the implantation of the left atrial appendage closure device. Go ahead. Yes, this is actually the picture that I like the most, and I think, I mean, the authors and the operators did a very good job in implanting this device, although there was this thrombus in the left atrial appendage. I'm not sure actually if the thrombus that they actually aspirate here was within the sheet, or was the original one actually taken in the left atrial appendage, but I guess, I mean, we can ask the expert, Dr. Natali, if I mean, he has some kind of opinions or advice. My question is that if he would have done the same, or if he would have protect the patient with one of the carotid filters that are actually also very fashionable nowadays. I mean, it could be something that you know, could be also used in this setting.
We actually did something. So there are a few comments I want to make. The first comment is that when you have severe smoke, sometimes the person performing ETE called that clot. And one strategy that we at other centers have used in this situation is to give either dobutamine or isoproterenol to increase rate and contractility to verify if it's a real clot rather than severe smoke. So that could be one initial strategy. If you then realize there's a clot, we have used the same approach in a couple of patients where we try to aspirate, but we have used also a protection device in the carotids. The issue with the protection device is that protect only the anterior circulation, not the posterior. So you still have a chance of some thromboembolic event, but certainly smaller. And we've used this idea of sort of sucking up the clot before deployment. Considering that the procedure from what I understand was done in Australia, I think in Australia they have approved device that have proximal delivery. So I would have chosen not the Watchman that had to be pushed deep into the appendage, especially in a situation where I would have chosen one of those proximal delivery devices like an amulet or even the Flex that is approved in Europe now. Provided option, or the wave crest is also approved. So I think that would be probably something that would have been my first choice, because so that I don't have to go deep into the appendage where the clot is. But you know, this is a strategy that I think people need to consider in situations like this, especially a patient that has such a very strong history for thromboembolic event despite anticoagulation. Another things that we do is to do the procedure on blood thinner, so we can stop it. In some of these patients with ongoing high risk of bleeding, sometimes we'll use half dose of NOAC, but we keep some ongoing blood thinner to minimize the risk. So but clearly this is a strategy that I think people could consider. I would prefer to use the protection device in addition to sucking the thrombus, so to be safer, but certainly an option.
Okay, and actually I want also to underline that your group was one of the first in the world making clear that heparin should be given before transeptal puncture, just because it's a very universal approach right now, but actually you were one of the first group demonstrated how much is important to heparinize the patients before going to the left side.
Transeptal access, and probably even more important in a patient like this.
Yes.
That's fantastic. Thank you so much, both. I will move to the second case now that has a title, An Unexpected Complication of Subcutaneous ICD Implantation and its Successful Management. So the first author is Dr. Tomoya Yagashita, and he's from the Department of Cardiovascular Medicine, Belland General Hospital in Osaka in Japan. So Antonio?
Yes. So this is a case of a 78-year-old man who presented with a non-sustained ventricular tachycardia during a routine echocardiogram. He went through a non-invasive checkup, and echocardiography showed a reduced left ventricle ejection fraction, which was equal to 17.5%. And he got NIA class, New York Heart Association class 2 heart failure, despite proper medication. And so the patient underwent, so there was a clear indication for implantation of an ICD. The patient underwent general anesthesia, as was put on positive pressure mechanical ventilation for the procedure. The authors selected a subcutaneous ICD, probably due to the fact that he got a very low body mass index. But during the procedure, since we are speaking about EP complication, the subcutaneous ICD insertion, while closing the ICD insertion site, so there was like a respiratory fluctuation of the wound, and so clearly a pneumothorax was suspected, and probably the pneumothorax was suspected due to perforation through the lead of the subcutaneous ICD. So the patient was so underwent fluoroscopy, and under fluoroscopy was clear. You can see clearly the left lung was actually down, and so there was like a diagnosis confirmed of pneumothorax. And what actually the authors showed in the pictures was the kinking of the lead between the two incision sites, suggesting that the lead was not totally subcutaneous, but was going through the tissue and was actually going into the thorax cavity, probably transecting the muscular layer and providing a pneumothorax. You can go ahead. So they were lucky to have like a lab which actually provide the same time possibility to do the CT scan in the lab, and these are the images which actually they got on the patient in the lab itself, which actually confirmed that the SICD lead had passed the thoracic cavity. And also they confirmed the diagnosis of pneumothorax with the collapsed left lung. Go ahead. And so an emergency thoracoscopy was performed. The images are really striking and very impressive. And yes, you can see actually the lead penetrating the lung parenchyma, and which actually confirm the primum movens of the pneumothorax. It was like a perforation due to the implantation of the lead, not totally subcutaneously, but in the thoracic cavity. Go ahead. So, which are the learning objective? Of course, especially I think in the patients with the low body mass index, which actually gives less possibility to use the real subcutaneous tissue to protect the lead while doing the tunneling. It's very, very important to understand where the tunneling is going on. And in this case, of course, I guess the authors recognize, this possibility. How to recognize a pneumothorax during an SICD implantation is like to see eventually respiration dependent fluctuation of the incision of the pocket of the SICD. And actually, a trick in the fluoroscopy was this kinking of the lead, which actually was very, very clear. CT scan was actually the diagnostic way to make the diagnosis, and they showed very nice images about that. I think, okay, if, this is the last slide. Wait.
Yes, that's the last one.
Wait. So I think, Andrea, it's a case, I mean, straightforward. I don't know if you can give the audience and a little bit of more advices on how to perform tunnelization. Yes.
Yeah, clearly this is a tunneling issue that many of us were very familiar with the day of sort of the long lead with the abdominal pocket. So we all went through the learning process. So I think it's something that people need to just be aware of. When you tunnel the lead, you have to stay superficial, don't it down. It's a technique issue. I think the important point you made very clear is the fluctuation. To recognize that acute complication is the fluctuation, the respiratory fluctuation of the pocket. This is a really a key point. But this is a complication about technique, tunneling technique that
yes.
obviously is to be something that the operator are aware of when they perform this procedure. The one comment I want to make is, you mentioned about the choice of the sub-Q ICD. I don't know if this kind of would be my preferred patient for a sub-Q, because he has a very low EF with non-sustained monomorphic VT. And to be honest, the can of the sub-Q is probably bigger. If you mentioned about the small body mass, but the sub-Q can ICD is bigger than most of the endovascular.
Yes. Absolutely.
So I probably, I would not, in this patient, probably I would not have chosen sub-Q ICD.
As a first choice. I guess the authors were actually also pushed towards the SICD because they were afraid to perforate the right ventricle in Yes, I guess, I mean, they had the images of the echo, and they were actually a little bit frightened by the frailty of the right ventricle, and so they decided to go ahead and to implant an SICD. But I'm totally with you in thinking that probably, I mean, this probably was a patient that was very difficult to manage either way.
So.
Perfect. The next case that we will discuss has the title Covered Stent Implantation for Treatment of the Iliac Vein Rupture During Percutaneous Left Atrial Appendage Occlusion. And the first author is Dr. Quentin Landhoff from the Department of Cardiology, Institut Montjuris in Paris, France.
Okay.
Again with
yes.
Antonio, yes.
Yes, so this is also a case of left atrial appendage closure device. So the patient is 82 years old woman. She was admitted for an elective percutaneous left atrial appendage occlusion procedure with an Amplatzer amulet device. She has in the history paroxysmal atrial fibrillation, transient ischemic attack. She already got a procedure for pulmonary vein isolation due to atrial fibrillation. She suffered from hypertension and they got previous episodes of lower gastrointestinal bleeding without any reported etiology. And on top of that, she also got a recent cerebral hemorrhage. You can go ahead. Here, I don't know if these are videos or...
No, there are still images.
Okay, there are still images. So these are images of the implantation. So just showing that the amulet was successfully deployed, that the prosthesis was stable at the final tag test. and so also the TE showed no leak. The patient, unfortunately, after the implantation, started degenerating hemodynamically, and so the TE, the first suspicion was, of course, pericardial effusion or tamponade, which was excluded. And so the authors, they were very clever, probably because they knew that of the difficulty they got in the beginning of the procedure to perform a selective phlebography through the femoral venous sheath, and they actually diagnosed an external iliac vein rupture with a massive extravasation of contrast into the retroperitoneum. So yes, they wrote that the breach was likely created by the tip of the torque view system during the first insertion attempt. But they managed the perforation, the rupture very well percutaneously, implanting a cover stent, and they showed also the images of the stent after the procedure. You can go ahead with the CT scan that actually showed very clearly the stent in the iliac vein with a very, very negligible venous leakage. So I think, yes, Andrea, this is a case probably is really an interventional cardiology matter, implanting stents. But I guess electrophysiologist, and this is what I want that you actually can say some words about. The word of electrophysiology is actually very, very close nowadays to interventional cardiology as well. So I think electrophysiologists should start or should continue to learn from these cases and start, grabbing or taking continuously information from the colleagues of the interventional cardiology.
So actually, I mean, the author should be congratulated because they thought about this complication quickly enough, because I'm aware of actually death with
Yes.
Complication like this, because the operator did not think about this as a possibility after excluding tamponade. And one technical caveat is that especially when advancing the sheet to deploy the appendage closure, those are large sheet, and you have to make sure that the wire is not kink and that the sheet doesn't sort of damage the vessel, as in this case. So it's not a bad idea to actually image the venous system as the system is advanced until you get closer to the heart, because those are a situation where this can happen. Is rare, but when you have this complication, that can be life-threatening, especially if you don't recognize it. So yes, in this case, they are really quick in thinking about this as a possibility, and they did the right things, because in this case, it's surgery probably would delay stopping the bleeding and could make this a life-threatening situation. So the stenting is probably the best option if you think about this as a potential source of the complication. Again,
yes. Yeah. No, that's a very good point, and yes, I want just to underline that in electrophysiology we are dealing more and more with these big sheets. We need also to think that the future is for leadless spacing, and the leadless spacing also bring to the field the very big sheets. So I think this case report should be taking into account, and I invite the readers and to even if it's not a pure electrophysiological case, to have a look, because it's very, very it gives very good teaching points.
Yes. Especially when you come down to a patient like this, 82-year-old woman.
Yes, exactly. Yes.
Yeah. So
that's perfect. So the next case that we will discuss is actually coming from the group of Dr. Natale. The title is The Subtle Journey of the Right Atrial Lead hemopneumothorax due to subacute pacemaker lead perforation. And the first author is Dr. Carola Gianni.
Yes, so this is a case of a 53 years old female who presented to the emergency department for recurrent right-sided sharp radiated to the right shoulder associated with shortness of breath. She was evaluated 2 weeks before for an episode of self-limiting 2-hour-long retrosternal oppressive chest pain without radiation, but associated with shortness of breath. The most important thing in the past medical history of this patient was that 2 days before the first ED evaluation, she actually was implanted with a dual chamber pacemaker. The indication was a symptomatic sinus node dysfunction. So the atrial and ventricular lead were bipolar, active fixation leads. And the implanted procedure was uneventful, and the patient was discharged the following day. So exactly routinary case. You can go ahead. So at the time of the second ED evaluation, a chest X-ray showed a small right side pneumothorax along with an ipsilateral small pleural effusion. The leads of the pacemaker actually showed to be in a normal position, although the authors recognized that there was like a change in the orientation of the leads in the chest X-ray itself. You can go ahead.
See, Antonio, so if you look at the upper is right upper, and this is the one after the symptom. So you see a clear shift.
Yes, absolutely. I mean, that's very clear. Yes. And I mean, it looks like the lead is pointing towards the perpendicular to the wall of the right atrium. Yes.
Yeah.
And I think that was the big issue. A repeat chest CT scan confirmed the presence of hemopneumothorax and showing the culprit. So there was a perforation due to the right atrial lead with a migration of the lead in the middle of the lung itself. Very rare, but very interesting complication, I would say. When actually we received this paper, we got enthusiastic by the fact that was really something very, very unusual and so much interesting for our readers. So no pericardial effusion, interesting, was noted, and the interrogation of the device revealed right atrial lead dysfunction, of course, undersensing and loss of capture with the maximal pacing output. I guess, I mean, there was also a change in the impedance that was clear related to the change to the migration of the right atrial lead. You can go ahead, yes. And so this is a clear picture. So there was an emergency think thoracoscopy procedure, cardiothoracic procedure. Mini thoracoscopy, okay. And yes, after identifying the proper rib space with fluoroscopy, the right side of the heart was exposed with the right anterior mini thoracotomy. And the mini thoracotomy revealed the lead through the myocardium and the pericardium. Yes, you can see it clearly there. Yes, exactly. Okay, that's it. Do you want to add something about this case? I mean, it's just very interesting by itself.
This is a very rare complication, but people need to think about because it happened that instead of causing pericardial effusion, you have actually pleuritic pain, and it's typical with the atrial lead. You don't have this. In the ventricle is always pericardial effusion, but with the atrial lead there is a chance that this can happen. So you need to think about, and it's exclusively with the screwing lead. It does not happen with the time.
Yeah.
And some people think that maybe the polyurethane are stiffer, so that could be so that the higher risk. Also, the length of the screw could have something to do with this. But beyond potential lead design and material, I think it's just a rare situation that people need to be aware of. when there is a patient coming back with the pleuritic pain. And it's one of the things that, you know, when we think about pleuritic, you always think about the left, where the implant is done.
Exactly.
But this is actually the right.
Right, yes, so, exactly.
So.
Yes, what I want to add, I mean, to ask you, if in your lab, I mean, you choose always active fixation lead for implantation, or actually there's still space for passive fixation leads?
No, that's I think is an American preference, and especially now that we tend to discharge the pacemaker the same day. Most of the operator use screw-in lead rather than tongue lead. Whereas in Europe, I think there is still a considerable, I don't know if you can confirm, considerable
use
of tongue lead. Yeah, this is, I think, is a sort of a practice, a sort of different practice in different continents, I think.
Yes,
US,
I can confirm completely what you're saying, yes.
Yeah.
That's great, thank you very much. Last case has a title Cardioform Septal Occluder in the management of cardiac tamponade as a complication of left atrial appendage closure. And the first author here is Dr. Nabil Breite from Wilson Medical Center in Johnson City, New York.
Great. Okay, so this is a case of a 77-year-old Caucasian female who was referred for left atrial appendage closure. In this case, warfarin was stopped 72 hours prior to the procedure, and the day of the procedure, the laboratory showed a platelet count of 156,000 per millimeters cube, and an INR of 1.68. You want to say something here, Andrea? But I mean, this. Okay, you go ahead. Yes. So the implantation was planned accordingly, and so the right femoral vein was accessed under ultrasound guidance. There was a transeptal puncture attempted using an SL0 sheet and C1 energy transeptal needle system. The system was managed, the author said, in the usual manner in the left anterior oblique projection using fluoroscopy and being helped by transesophageal echocardiography. The sheet was advanced over the needle. However, contrast injection confirmed sheet position to be not in the left atrium but within the pericardial space. And this was actually due to perforation likely of the posterior wall of the left atrium. Go ahead. So this is the video of the transesophageal echocardiogram, which actually showed a rapidly accumulating pericardial effusion, which actually brought to hemodynamic instability. The patient was not anticoagulated given the pericardial effusion. And so the cardiac surgeon was called, and he went ahead and performed, so he did a pericardial window, which allowed to evacuate around 400 cc of fresh blood and clots from the pericardial space. Pericardial drain was placed through the sheet. But I think the patient was still unstable, and there was still blood coming through the window, and so to prevent further bleeding into the pericardial space, it was felt that sealing the left atrial perforation was necessary. And so instead of going ahead with the regular cardiac surgery, the operators thought to adjust the perforation in a percutaneous fashion. So a Gore cardioform septal occluder device was advanced over the amplatz wire, so was placed in the it was apposed in the hole that was actually in the pericardial space, and this disc of the septal occluder was exposed in the pericardial space, whereas the proximal disc was exposed within the left atrium, and so the device was resealed with a good approximation of the left atrial tissue. I guess the patient was stabilized with this maneuver. No further pericardial fluid accumulation was noted. And afterwards, the patient was transferred to the cardiac intensive care unit. These are the images, the videos after the procedure. Yes. Yeah, you can go ahead. So, of course, these are actually is a complication. So it's a clear complication of pericardial effusion due to puncture of the posterior wall of the left atrium. So the authors suggest, of course, that imaging guidance is fundamental together with pressure monitoring during transeptal puncture. The use of a 4 or 5 French pigtail catheter inside or a looped wire in the left atrial appendage to facilitate a safe approach into the left atrial appendage in order to avoid eventually the use of a transeptal needle. They advise also a careful and slow catheter and device manipulation within the left atrium. And finally, after, they implanted the septal occluder, TAC testing, it's important to confirm the stability of the device, and the TE should also confirm the absence of further leakage.
So this is the end of the case.
I want to make a few comments. So one is that, so this is clearly, this is an issue with the way they use imaging, because with TE that should not happen. But it's typical of this procedure where the axis is posterior. So for a closure device, what they tell people is to go low and posterior. And the reality, if you go too posterior, you actually enter the pericardial space. So that's something that with imaging should not happen. Clearly, in this case, they have this issue. So obviously, proper use of imaging is one issue. The other one comment I want to make is that I don't know if I would have used there are smaller devices. The cardioform is a pretty large, as you've seen in the fluoroscopy. Yes. There are other smaller closure devices probably I would have chosen for this specific use, and they've been used also in the free wall of the left atrium, in the left atrial appendage for similar situation. So probably this will not be my first choice for this application, but it works. There is no doubt it works. And obviously in this case they already have access to the pericardial space, so it was really with a larger size transeptal sheath. So it was really about advancing the system and deploying. So certainly easier.
Yes, for sure. It was like a choice. Even if, given the situation and the possible need of a cardiac surgery and the possible need and the need of the patient to close the appendage, probably a cardiac surgery with concomitant left atrial appendage clipping or could have been also, I think, an option. Yes, but probably, they were, the operators consider that the best choice for the patient during the procedure, of course.
That's fantastic. Reaching the end of this webinar, what are your comments in general about complications, the operators, especially for the junior fellows that they may attend this webinar?
What I tell, I've been doing intervention for many years, but I think one key aspect is never feel too comfortable. You need to follow specific rule, and that's probably the best way to avoid complication. I think when you get too comfortable is when you make mistakes. So this is what would be one of my teaching points.
Antonio, any comments from your side?
I think, more than Andrea, it's very difficult to to do more comments than himself. I mean, he has real one of the most significant experience in EP procedure, complex EP procedure. I would say the same, but I guess, I mean, one little thing that I can say that we need never to stop learning, and this is something that actually exactly comes probably when someone feels confident that he has learned what can be learned. And I think JACC case report is doing a very good job in providing these cases, which actually are, I mean, I'm learning going through them every week. They're giving a lot of hints just because you can share experience that cannot be accessed in any other way. So I think learning, continuous learning is the key to keep the complication low. Yes.
It's actually very good that people are willing to report their complication, because we all learn by these cases, either in preventing them, you know, if there is a way to do that, or in sort of having a strategy that might be less invasive for the patient, like in some of these cases.
And I think also that these cases, Andrea can help you to figure it out, which could be the next trials. I think, yes. I mean, the little cases can open very, very nice pathways. And I mean, I think what you did on the left atrial appendage is clearly something that is giving you, at the end, a lot of satisfaction. And that's one question that I always have in my mind, is that how you started thinking about the left atrial appendage as a trigger in atrial fibrillation. I mean, this is like a $1 million question, but I guess everyone asks himself how actually you did get there.
Thank you so much, both of you. I will just remind the audience to subscribe to JACC Specialty Journals podcast. And I'm really grateful because I learned a lot from both of you. Thank you.
Thank you, Julia.
Thank you, Julia.
Thank you. Thank you.
Bye, Antonio.
Bye, Andrea. Thank you very much.
Thank you very much.
Thank you.